Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hi, everyone. Welcome to another episode of the JMMT podcast. My name is Dhinu Jayaseelan, and today I have the pleasure of being joined by Dr. Sean Riley. Dr. Riley is an assistant professor at Sacred Heart University's physical therapy program. Something he shares in common with me is he's also an associate editor with the Journal of Manual Manipulative Therapy, JMMT. Dr. Riley's published extensively in the area of orthopedic manual physical therapy, but today we'll be talking about his recent paper in JMMT, which was co-authored with Brian Swanson, Stephen Sawyer, Jean-Michel Brismy, and Jeffrey Stasniak, titled "Should Low-Quality Evidence Dominate High-Level Evidence? A Systematic Review and Meta-Analysis of Systematic Reviews of Musculoskeletal Physical Therapy Interventions." Dr. Riley, thanks so much for joining us today.
Thank you very much for having me.
I always want to start by just kind of getting motivation for this. So can you start by kind of giving me an idea of how you and your team started into this project and then an overview of the paper itself?
Well, I think where we really started with this was we were looking at some systematic reviews, and it looked like some of the systematic reviews, the RCTs, the way that they were graded as far as quality, there really seemed to be either very high or very low. So, it really started where we're just kind of curious to see if somebody, a researcher, graded this on say a Pedro score, would that Pedro score kind of match what is on the Pedro's official website? And then from there, we started to look at some other critical elements of what was included is there a difference between the quality of the study, the RCT that's included in the systematic review, and the quality of the systematic review itself? So that's essentially where we started with this project, and then it just started to snowball from there as far as some of these other variables that we looked at.
If you had to kind of describe the biggest findings from the systematic review and maybe the methods of it, what would you say are some of the bigger take-home points?
I think the biggest or bigger take-home points from here is that our systematic reviews should be registered through Prospero, and we found a large number of these that weren't registered. So as far as the number, 63% of the systematic reviews were not prospectively registered. And I think that's a challenge, that when you're looking at a systematic review, it should start as a question, and it should start as a PICO question. And that PICO question should be registered a priori. So, and that's important, that any research starts with a question and then goes through the process to see if they could potentially answer that question, and not start with the answer and then see if they could find things that just support the answer. So I think the important thing for us is we should be really thinking about, is this study registered? Is it registered prospectively? Does the registry, the publicly available registry, match the study? I think the other thing that really jumped out at us when we looked at the RCTs that were included in the SRs was that we looked specifically at systematic reviews that use the Pedro score, and the first criterion for the Pedro score involves the inclusion and exclusion criteria for the RCT. And we found that 58% of the SRs included RCTs where that didn't meet that inclusion and exclusion criteria, that external validity. So it's like, how did you include this study to answer this specific question if you couldn't even identify who the findings of this study apply to? So those were two of the biggest findings from our perspective.
for me as an educator, as a clinician, as a researcher, and as an editor with JMMT, this brings up a lot of interesting topics. One, I think everyone always believes, systematic reviews, clinical practice guidelines are the top tier in terms of that evidence pyramid. Your systematic review, which was albeit limited in to the Pedro, so there's a lot of other things out there. It's really showing that the quality of evidence that goes into systematic reviews is not as high as we would like it to be. So I think it kind of shakes the foundation a little bit to show us that we need to kind of pump the brakes a bit when we interpret the conclusions from these systematic reviews, because what goes in might not be the best.
Yeah, I think what we need to do when we're looking at literature in general is really be able to look at it and to get an understanding of what quality is and what quality isn't. It's a process when we're looking at this literature to really go through and critically appraise it. So the use of evidence-based practice just isn't, combining the evidence with patient values and clinical experience. You really have to be able to look at this literature and go through that process of identifying what is the highest level, what is the best quality, and does this study, the people that were included in this study, match the patient that's sitting in front of me. And then those other elements are integrating that information into that clinical context, as far as with the patient's values and alongside your clinical experience.
Yeah, and I would also kind of on top of that, um, almost caution people based on, I think sometimes the tendency is to kind of read through the abstract, find the conclusions, kind of sift through maybe the study a little bit. um, I think one thing that should not be a takeaway from your study is that systematic reviews should not be used. Is that correct?
I'm not saying that at all, and I'm not suggesting that at all. But what I would suggest is that as we evolve as a profession, the rigor of our science needs to evolve also. So if we're going to really look at this and say that we are a profession that's based on scientific evidence, and that is a thing for us, then as we evolve, our literature needs to evolve. And we're not the only profession that has this challenge. you know I- y- there's same and similar challenges in medical literature and in other literature. But as we evolve, we just need to say, this is what we do well, this is what we're not doing well, and this is what we need to do to get better and evolve.
Yeah, and one of those ways is to identify where's the quality of our evidence, starting from the top down or bottom up. Um, And I mean, for JMMT and some of our listeners, a big component of what's being used is manual therapy, right? And in a lot of the manual therapy type of intervention studies, the Pedro is the quality measure for internal external validity. But with manual therapy, it's like almost impossible to blind the intervention, and that's one of the components of the Pedro. So manual therapy always is going to be graded lower with the Pedro. So do you have any kind of guidance for listeners or for consumers of research when you're considering manual therapy studies, for the scores on the Pedro?
As far as the Pedro is concerned specifically, like this is a like what criteria we're using as far as assessing the RCTs for their inclusion into the systematic reviews, I don't have any simple answer to that.
Right.
Many people are very critical of the Pedro and the Pedro score because it was developed for use in pharmacological literature, and that it may not translate into musculoskeletal physical therapy interventions, for example, and that other tools are potentially better based on their constructs. Um, I'm not here to throw shade on any of these different tools because I haven't come across, I've heard these comments, but I haven't come across anything that says that shows objectively that this is better than this based on this. It's
Right.
largely considered to be better than this based on this because of the constructs that are included within it. So if you look at, for example, the Pedro score in the Cochrane collaboration risk of bias, like, they're different tools. They're supposed to measure different constructs, but they're more similar than they are different as far as they correlate. Are these mutually exclusive tools, and then you know which ones are the best? It may not be the constructs. Maybe it's the ones that are most related to each other, or one that's related to other. Gets other the most aspects that we're really interested in. But I
Yeah.
think that question in and of itself is probably beyond my pay grade.
Mine too. That's why I asked you.
Yeah, I'm not.
So
I'm not sure. To,
yeah.
there's. I've heard the discussions. Not sure that I know enough about it to say definitively. We should stop using the Pedro and we should just use this tool. I do think that one of the things that we really saw in our study is that we were really trying to create a homogeneous sample, so we just used the Pedro score. So good, bad, or indifferent, the Pedro score is still the score that's used the most in order to take a look at the quality, the internal and external validity of the studies that are included in systematic reviews. So for us, there were still 50 other studies that used a different measure or combinations of measures or modified measures. So until that variability in and of itself that we try to control for, there may be better tools out there that, if this tool was used, would improve the quality of the systematic review process.
Right.
Given the wide variability, I don't know if we can answer that question. One of the reviewers' critiques of our paper was that they felt that the reason that we found all of our studies that we found, the systematic reviews that we found, were low or critically low in quality on the Amstar 2 was because we chose the Pedro scale. And if we chose another scale, that the Amstar quality may have been better. Well,
Hmm.
it may have been better, but there just isn't enough sample, you know what I mean, to answer that question. I mean, if you think about what we did with the study, we looked at 24 systematic reviews, and then we looked at the studies that are included inside those systematic reviews.
Right.
So this is a 2-year project, and I appreciate what the reviewer, just to get the data. So I really appreciate what the reviewer is saying, and I would have loved to made those comparisons. But now we did that for the Pedro. You'd have to do that for another, and then see, does that really impact? And I'm not sure it would. But I
Yeah.
think
And
that's a good question.
I think it's a good question, but it's also a different question than what you were asking.
It
So
absolutely, and that was the point that we made to the reviewer. I'm like, yeah.
So one of the things that was interesting to me that you guys mentioned in the study itself was perhaps thinking about systematic reviews maybe having a cutoff point in terms of the quality of studies that they're going to include. Um, so, as an example, maybe less than 6 on the Pedro would be an exclusion criteria, maybe just because the quality isn't as high. What are your thoughts on people that might say, well, the systematic review of a specific clinical question based on a PICO should look at all the evidence that's available for that, whether it's good or bad evidence?
I think that's a good question, and I've seen both sides of that study to say that you're going to have a more robust finding if you just, if you're going to do a meta-analysis, that get all of the data and then see how that data shakes out. I think when you're talking about lower scores or lower quality, we're really talking about internal validity of the study. Like, is this thing valid enough that it should be included? So we've done a systematic review before where we looked at that, and I would say that if there is enough literature out there on the topic where you have, let's say, I don't know, 100 and something studies, your findings may be more robust if you use that as one of your exclusion criteria.
Hmm.
Now, if you do a systematic review where it's all low quality and there's no high quality, or there's very few studies, having, doing a systematic review that includes both high and low quality may be appropriate. So I don't want to say always or never, but if you have a, a significant number of studies, I think the question that we're really concerned about here is that if you have a certain number of low quality studies and they're saying something completely different than the high quality studies. So, say that the high quality studies are saying, well, this is something that we should likely rule out and move on. Where the low quality studies are saying, no, we should keep doing that. Potentially being more proficient in our process, and can we maybe say, okay, we've hit a critical mass of high quality studies. And it's interesting because I can see both sides of this argument, but you can see in a number of different research studies where it doesn't even require this critical mass. Researchers recognize that, all right, we should likely move on from this. After seeing a small group of high quality studies on this. I think the one that sticks out in my mind the most more recently is the concept of scapular dyskinesis, where I sat in at an AMP conference a couple of years ago, and Lori Michener, like, systematically with her literature, dismantled this whole concept. And people from the audience were like, yeah, but, and this, but, and she's like, well, I spent 15 years of my life doing this, and I put a pin in it. We're moving on. So at some point, like, what is that and how do we get there? So yeah, I danced around that a little bit.
That's all right. That's pretty
Because
pretty
I
good
can
dancing.
understand both sides of it,
Sure,
as far as, always or never. But if we're
but that's
looking
not clinical
at,
practice. That's not research. Always or never doesn't exist. I mean,
right,
you want to try to get there, but it's a process that we never
but
should
if
stop. You
but
know.
if we have, so I gave that as one example, but there's a number of different examples, and I don't want to go down too many different paths with that because people will be throwing rotten tomatoes at me. But there are a
Yes.
number of things that we have walked away from as a profession
Right.
after a relatively small number of studies. So the question is then why don't we do that for other things that have more robust research?
Right.
And is that because it's blended with other things that um, change the story?
Right. Well, I mean, coming back to the quality of these studies and the way we're interpreting them, I think one thing that often goes underlooked is the way they're reported. And so I've published a number of systematic reviews. Some of them are based on lower quality evidence, not as high quality. We're also working on one right now where we're grading patient reported outcomes and the translation of them for a health condition. And if the authors don't put in certain words based on the grading criteria, that's graded a lot further down than it would be had they maybe done something but just didn't report it. So, like as an example for your study, you guys looked at if the electronic search wasn't done by a librarian or a professional librarian, potentially unbiased to the question, then that gets graded down because of the potential biases and just lack of quality that's associated with that. Perhaps what if these studies had that, but they just didn't report it? Maybe the quality of these studies isn't bad the way they were performed, but maybe the way they were written up and reported. What are your thoughts on that?
No, I agree with you. So was it not done, or was it not reported? Did it make it to the did it end up on the cutting room floor? And that unfortunately happens just with the simple, um, when you're looking at word counts. Like, you go through and you include all of the details that you would like to include, but then you have to also tell a story within a certain framework. Like, how many words do you have to tell those stories? So often some of those details are lost. So I think in that context, I think it's important to reach out to those authors and really, and in my experience with that has been that most of them will get right back to you. Surprisingly, they'll share data sets and some other things. So um, we probably do need more. We already have more standardization as far as reporting. We don't want to make it so rigid that it doesn't take into account the individual differences of different journals and what's but there should be some key elements there that should always be present in reporting RCTs so that they can be compared apples to apples. Um, and most of the time that ends up being like numeric pain rating scale,
Right.
something that's universally used in all studies. But to make that more robust, maybe, and because studies don't reflect enough of what improvement is as far as objectively, subjectively, and related to the patient's experience, related to its impact on their self-efficacy and some other things. Like, there, we may want to look at a few different constructs outside of just pain. Something that was met. So most of the outcomes that we have when we look at these studies, we're not looking at anything that was measured by the clinician. Most of them include subjective outcome measure. But if maybe we had, when we look at these studies, if we included something that was subjective, something that was objective, something that was related to positive or negative psychological variables like fear avoidance and self-efficacy, and then what was their experience like with their interaction with the clinician. So I don't think I think what we capture with systematic reviews and what we capture with RCTs, we probably need to make, because those things are all different. They don't necessarily correlate. But at the end of the day, and I'm sure you and many of our colleagues have seen this in the clinic, where you give somebody an outcome measure, they fill out the outcome measure, and you look at it, and they haven't improved. But if you measure the range of motion, strength, these other objective things, so from they have improved objectively, but subjectively they have not improved. So potentially recognizing that and then helping them make that connection may help with that patient's experience, because they
Right.
only improve if they think they improve, independent of whether they objectively improved.
Right. And then the reporting on the outcomes, based on what a study team is going to be looking at, that could be variable. You would hope that there's going to be at least a validated outcome measure that's used across disciplines or across countries is used consistently. Some people might actually say standardized reporting comes back to the journal. That the journals and the editorial team should be looking at a standard way for authors to be looking at things. One of the things I saw in your systematic review was you tried to identify the journal impact factor and the quality of these studies. And if I'm interpreting it correctly, it seems that even though a vast majority of studies you looked at had lower quality going in, and maybe the quality of the reporting wasn't as great, it seemed the trend at least was that higher impact journals were including higher quality papers. Um, and obviously, there's some stuff that goes into the impact factor, a lot of stuff that doesn't seem all that relevant. And sometimes those impact factors are incorrect. I know JSPT had a lower than preferred impact factor recently based on some different variables. But c- is it possible to be more confident that these higher impact journals are producing higher quality papers, and just knowing that it's coming from JSPT or British Journal of Sports Medicine, it might be higher quality off the bat than something maybe off the beaten path that I haven't read before.
Well, I think there's a number of different questions in there. I think, first of all, if we're looking at impact factor, What really constitute impact factor? So people would suggest that it's the number of citations from a journal, or the number of citations that from papers that have been published in that journal. And when we looked at it, that just doesn't seem to be the case. So as far as the methodology of what is used to create impact factor, they're looking for journals that are in a certain quartile. So second quartile, just to be have an impact factor, independent of what how it's traditionally calculated. Um, the question then becomes, if you look at a journal with a certain impact factor, they are typically going to have higher quality research. So when we look at some of our colleagues that are in Australia or in New Zealand, they are required, when they seek publication, to really target, if they're really looking, their culture is, hey, we need to have high quality stuff because we need to get our stuff into a high impact journal. And that is their motivation, because it relates to tenure and promotion, and other things along those lines. um, so but making the connection between, you know impact factor and quality, um, I can't you can't say that these are the same. So you can't say that if you look at a higher impact journal, that you're going to have higher quality, you know because it may not be the case, but you are probabilistically more likely to have more higher quality product.
One of the important things when it comes to publication, especially writing, regardless of which journal it goes to, is the way it's presented, the way the results are presented. And one of the things your author team looked at was the spin, and so um, whether I'm reviewing for JMMT or any other journal, one of the first things I'm looking at is, do the results match the way you're presenting the results? Is there a bias in that? So um, I want you to talk, if you don't mind, a little bit more about what is spin, and if you think spin is maybe a bad or a good thing or somewhere in between.
Well, as far as spin is concerned, when you're doing any study, your discussion should match your results. Your conclusion should match your results. And I think it's okay to have a conversation on interesting findings, but then to represent those findings as, I meant to do that, is a whole different thing. So when you're looking at your results, you should be thinking, okay, these were our primary outcome measures, these were our secondary outcome measures. This is what we found here. These were some other ancillary potential findings. But I think where spin really comes in is when people say, well, there was a statistically significant difference between these groups or within these groups, but those difference in represented is something that, wow, this is really great. When the difference represents a very small effect size, and is not larger than the measurement error of the tool that was used, or the minimally clinically identifiable difference. So I think, you know that's really what you have to look at. And I think that's kind of the trick, is that, okay, there is a difference there, but is it a meaningful difference, and more importantly, is it a clinically meaningful difference? And when people just focus on one or two you know one or two outcomes, and ignore all the other outcomes that don't support the message that they're trying to say, I think you have to be sensitive to that. I think, for me, as I've evolved, as somebody that has looked at these things and is started to write a lot of these papers, it's very easy to do that, to spin. And you always have to really check yourself, is like, am what I writing here, is this consistent with the facts? So I think I think spin is really dangerous when you have a busy working clinician that just reads the abstract or the conclusion or the discussion, and doesn't, or maybe doesn't have the skill set to take a deep dive into some complicated analyses and really see if the results match those other elements. But I think that's another important consideration to look at.
Yeah, and then when I was reading this study and then kind of reflecting on my own interpretation of research and then dissemination of research, it's also really important, whether you're the researcher or the consumer editor, whatever it might be, to kind of think about your own personal biases. Like for
Hmm.
me, I've fellowship trained, I have certain thoughts on what's helped people in the past. And so I might have opinions that might guide my interpretation. And that's human nature, right? So it's easy to agree with something that is agreeable to us, and it's easier to disagree with something that we don't want to believe in. Um, and those interpretations kind of come in when we look at research. So I also started to think maybe the quality of the evidence is actually potentially really good, and the studies might lead us one way, but on the back end we have to be able to those conclusions objectively and make sure that we're not being the problem with research by interpreting it incorrectly.
And I also think it's important that you surround yourself with people that are not afraid to tell you how it is. Like if you you read a research study and you get a certain impression from it, or you're interpreting it another way, I think it's important to have somebody else, have a conversation with somebody else, who may have a slightly different perspective, or is approached how they went through it slightly differently, and often can open your eyes to your own blind spots. I've certainly have done this, like when I've been writing a paper and I write the discussion, and you get that comment from a colleague that says, "That's a pretty strong statement there. Is that supported by the literature?" Like, yeah, you got a strong point. So I think whether we're creating literature or whether we're consuming literature, I think the conversation that we have with colleagues, especially those colleagues that are that may be more critical than most people like, and but those colleagues that have reasons for and explain why they're critical, I think is important when we're consuming this literature to, because we can easily weave that web of things that match our favorite beliefs.
Right.
um, but I think we can't grow as clinicians unless we are consistently challenging our favorite beliefs constantly.
Right. And I mean, for me, that's what fellowship training was. That's what reflective practice is in general. But it actually really that kind of leads me into my kind of last area that I wanted to discuss with you is some advice for these consumers who's going to be reading this research and what takeaways can they have from this? Because, for me, um, I'm in academics full time. I do some clinical practice, but my job is teaching and research. And so I'm able to stay up on some of these topics, but just knowing a couple key questions, there's so much stuff that comes out every single month from so many different journals. And it's tough for me to keep on top of this stuff. And so I know from my time as a full-time clinician, it's very difficult, to be immersed in good consumption of evidence. And then based on this review, we have to now start to question, the evidence that's coming out. We have to question that a little bit more maybe than we thought. Again, not tossing it away, not throwing the baby out with the bathwater, but really just being able to dissect it a little bit more. Um, what advice do you have for more of the busy clinician, maybe the novice clinician, or the person that doesn't have 3 hours every single day to look through literature? What advice do you have for them to be able to maybe more efficiently and effectively sift through this data?
Well, I think there's a number of different forums where you can get easy access to different literature, as far as different papers are concerned. But I think getting involved in different conversations, whether it is through um, a journal club or other things along those lines, that where you can interact with others that maybe have a different skill set than you have as far as interpreting the literature. I would also suggest looking at it with a skeptical eye, not looking at just what supports your opinion. Look at those things that potentially don't support your opinion. I think what for us looking at the literature in this way, I don't want to say that it's all no good, and it, Phil Sizer, years ago, said to me, he goes, Sean, because I get excited about stuff, and I'm like, hey, look at this. This is so great. And I remember him looking at me one time and just saying, Sean, this is not a revolution. It's an evolution. And that's kind of what I see with our literature is that as clinicians, we need to be able to reflect on action, meaning we got to the end of the day and this is what went well, this is what didn't go well, and this is what we need to do to get better the next time we do it. And the more proficient we get and the more experience we get, we can reflect on action where we can say, we can recognize in the moment that we're doing this and, oh, this isn't going well. I better change my approach with my interaction with this individual. But I think that also applies to our literature, is that it needs to evolve. It needs to evolve, in order to potentially decrease variation in practice. It needs to evolve to be more easily consumable, so that the working clinician, they can have a high degree of confidence that what they're picking up is something that is a certain level of quality. But we also have to think about, when we're doing that we don't make this thing so cookie cutter and so precise, and that the internal validity is so high that it really doesn't translate. It doesn't look like clinical practice. So it's easy to sit here and throw darts at where we are now, but there was a time when we didn't have literature. Now we have a lot of literature. And we have some literature that is coming into play from potentially less than scrupulous journals that are potentially masquerading as. So I think, beyond just looking at that, we have the quantity, but now we probably have to reflect and try to improve our quality.
And there's a lot of good ways to do that. I think one of the ways to start is by just taking this paper and realizing, our starting point is maybe different than what we thought. Trying to find ways to elevate our practice, trying to find ways to elevate the rigor of the studies that we're using, trying to elevate the rigor of our systematic reviews and our syntheses of the evidence, and then using that higher quality uh, evidence to guide our decisions on where to go next. I think that's really important. I think it comes back to continued investigation, such as yours and your teams. So I appreciate you guys' effort with the paper. I'm glad to see this is published. I appreciate you taking the time to chat with us about this paper and implications, whether it comes to research or clinic. Typically, towards the end of this, when we actually go ahead and put these up, we typically attach show notes, including contact information. If our listeners have any questions, do you mind if they go ahead and toss you an email or give you a call to follow up on this? What's the best
Not
contact for you?
No problem. My email address is Riley, RILEY, the number 4, at Sacred Heart, all one word, .edu.
So, obviously, if anyone has a question for Dr. Riley, please feel free to reach out. Dr. Riley, I appreciate you taking the time to chat with us. Thanks so much.
Thank you very much for having me.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.